Hello, everybody. Welcome today from Montreal to today's Cardiovascular MR Journal Club. And we have two quite interesting papers today. And without much further ado, we'll jump into the first one. I would like to ask Kady Fisher, who's the first author of the paper we discussed first. And it was published in PLOS ONE during this year, and it's called Association of ECG Parameters with Late Gadolinium Enhancement and Outcome in Patients with Clinical Suspicion of Acute or Subacute Myocarditis Referred for CMR Imaging. So, Kady, I'll hand over to you now.
Okay, can you hear me okay? Yeah?
Yes.
Perfect. So thanks. So I know there's been quite a few myocarditis papers lately, and this is ours using a cohort from Boston. And so we all know like CMR is pretty key for investigating myocarditis, and as we showed in this cohort, along with quite a few other studies, LGE is a pretty strong prognosticator in myocarditis. But of course, CMR can't always be the first exam that you send your patient to, and it's not universally accessible. So we kind of wanted to look at a more maybe clinical approach. So we wanted to look at ECGs. As we know, they're more available, especially outside of these tertiary centers. And often it's more likely to be performed, especially when your patient is first coming in with the symptoms. So as myocardial scarring can impact the electrical pathway and lead to conduction delays, we wanted to look at first the association of ECG with LGE, and then also if there's any combined prognostic value of these ECG markers. And so some other groups have also been looking at this as well, publishing in maybe smaller samples with these fragmented QRS complexes or wide QRST angles from the ECG. So we wanted to look at these two with our bigger sample size. And so for this, we used one of these larger retrospective databases from Boston. And yeah, if you're unable to find our little pathway, PLOS ONE made it helpful by making it the entire page. So what we did is we took everyone who was suspected for myocarditis. And then, of course, after excluding for other comorbidities such as coronary artery disease, etc. We needed people who had a current ECG. And then these are patients who were scanned from about 2002 to 2015. So for this, we made the final inclusion criteria based off the 2013 ESC guidelines for myocarditis. So it does include some edema and LGE findings, but also with high troponins and wall motion abnormalities, etc., for the inclusion of myocarditis. And then we'll get to that. It's because everybody in this cohort does have a standard sine function in LGE, but as we did start scanning in 2002, we of course didn't always have T2 for all the images and later on. So we didn't actually have many criteria that you could use now from the Lake Louise criteria for including the patients. So anyway, we had 585 patients basically. So what we did is we had reanalyzed all the ECG afterwards by one reader. So we didn't take the clinical findings, and we looked for these more common parameters, of course, such as the ST elevation, ST depression, but we also wanted to look at these QRS complexes. And these are pretty well defined in the paper as well. There's quite a few different ones, but mostly it's either additional notching or notching in the RNS waves of your FQRS. And then we also looked quite a bit at the wide QRST angles. And these had to be present in at least two neighboring leads. So patients, they were followed up to 14 years with a mean of 3.9 years, or median, sorry, 3.9 years follow-up. And then we looked at these for the outcomes, so major adverse cardiac events, and these are defined as either all-cause death, hospitalization for heart failure, transplant, or sustained tachycardia, or recurrent myocarditis. And then let's scroll down to this. So patient characteristics are pretty standard. And what we did is we defined the patients when they came in for the MRI as either having acute symptoms, so they had their MRI within 2 weeks of presentation, or the subacute with 2 to 4 weeks, and it was about half and half for these populations. And then when we looked at the actual ECG findings, so here in the first column, we have the prevalence of these ECG. So 78% of our population did have an abnormal ECG, defined by the post hoc analysis. And the most common parameters were either prolonged QTC, and also fragmented QRS was in nearly a quarter of the population. And then when we wanted to look at their univariable association with the outcome, we found that similar abnormal ECGs were associated with outcome. Again, this wide QRST angle, low voltage, and a prolonged QTC. And then for MRI, of course, we have the standard parameters. So just under half of these patients had visible LGE, and this, of course, was still associated with MACE. And then we also did another variable. So we didn't specifically diagnose dilated cardiomyopathy in this group, but we looked at dilated volumes and a reduced ejection fraction. And same, this is also another association with MACE, but we didn't find any connection with most blood markers except for NT-proBNP. But again, as this was a retrospective database, we just had to go off what the practicing physicians ordered. So these were mostly available and only about a quarter of the population for the blood markers. And then, oh, sorry. So this was, of course, 94 patients did have MACE during these almost median of 4 years, with about 27 deaths and 38 heart failure and 22 cases of arrhythmia. What we wanted to also see was the link of association of these ECG markers with specifically LGE. So in the supplemental, we also provided ECG markers with T2, pericardial effusion, and the T1 that we did have available. But mostly same thing. If you have an abnormal ECG, it did increase the chance of having LGE as well. And we saw this for the same parameters that we saw that were associated with MACE, which is ECG, wide QRST angle, no voltage. And we also saw that the FQRS had the largest association with the presence of LGE. And sorry. And so we made this take-home figure. And in the inside, you can see the gold lines associate which ECG markers were associated with which markers. And of course, LGE and also LVEF and pericardial effusion were quite often associated with ECG. And then on the outside, by these red lines, these link the univariate association of MACE as well. And then what we wanted to go look at was these multivariable models. So of course, due to a limited amount of events, we made 2 models. The first one is a more imaging based. So we of course have our age and our sex. And then we have a few more imaging parameters with LGE, our end-diastolic volume, LVF. And then we made a composite ECG variable of these significant markers of wide QRST angle, low voltage, prolonged QTC, and FQRS. And as you can see with this, LGE still maintains its significance, and this combined ECG marker has an independent prognostic effect as well. And then model 2 is more based on the individual ECG markers. And always, as we see, LGE is significant, and then along with this wide QRST angle and low voltage. And so this is for the multivariable models for MACE. And then finally, we wanted to look at this combined effect. So this black line here is in these patients where there is no LGE or there's none of these composite ECG variables present. And of course, the cumulative incidence is quite a bit lower when these weren't present at the time of CMR. And then if you look at, the gold line here, this is when there's one factor present. And then of course, if you had both LG and ECG present at the time of the CMR exam, then there's a much higher cumulative incidence. And sorry. And then so, of course, these connections between ECG and the CMR can be also based on when the CMR scans and the ECG were done in comparison to the presentation. And I should also note we specifically were looking at the association of ECG for diagnosis of myocarditis, but more its association with its prognostic ability. And in conclusion, what we can see, sorry, just scrolling down here. And also in addition to that, we do provide a lot of information in the supplemental about the findings in the acute and subacute presentation of populations. But in general, in this pretty large cohort of just under 600 patients, we can see that the wide QRST angle and a low voltage do have independent prognostic value for future MACE. And what we also saw as well, FQRS doesn't have its own prognostic value. It was one of the markers most associated with LGE. And somewhat independently, there also was a paper quite recently that showed that like FQRS was good at predicting LGE persistence. So maybe it's different. It's not so much for the MACE, but it could be used for something different. And in overall, integrating both this ECG and MRI could improve risk stratification, especially with myocarditis, which is a pretty heterogeneous population. And sorry, if you have any questions.
No, thank you very much. That was a great presentation. Although I hear that I'm pretty sick, I'm sorry for that. I hope you get well soon. No, I think before others think about the questions, and again, everybody who wants to ask a question, either just unmute yourself and speak up, or type it into the chat box, and then we can then discuss it. So I think, first of all, congratulations. I think there was a great paper, not only because of the sample size and prognostic data, but also because I think the marrying ECG with CMR findings has been done recently in a couple of studies, and I always find it useful not to basically replace, let's say that ECG would allow us to diagnose whatever, but in order to have a better understanding what causes these ECG abnormalities. So I feel that we all have learned recently quite a lot on what an ECG can offer. For example, that a T inversion has been associated with edema, then QRS dispersion, like you showed here, is associated with intramyocardial fibrosis, and I think there is even more to do. And now, then with advanced statistical methods and machine learning, we may be able to extract even more information from ECG. So in a certain sense, CMR gives back to older technologies, and ECG is one of them, that have been changes that have not been that well understood. So that's why I found this really a great paper. And of course, your figures are always very creative, and this one is excellent, because in one figure you show all the information on what is relevant for the prognosis and which ECG markers should be taken care of. So I wanted to congratulate you for this fantastic paper. So from your point of view, if you would have to make up your mind in a patient on the emerge, and you have certain ECG markers, so with your experience, would you be confident enough to say, okay, this is probably going to be myocarditis, or do you think we would still need both, just from your feeling?
Well, for me, so I come from the scientific point of mind, so it's send everyone to the MRI, but like, again, we weren't so much looking at diagnosis. So, I mean, you could, of course, take in your patient population. So, if they're younger, it's much greater chance of myocarditis. But a lot of these features have been associated with, coronary artery disease as well, or acute symptoms. So I think you still have to take in everything for the suspected myocarditis. Yeah. Yeah. And of course, the availability on the MRI can probably impact this quite a bit.
Yeah. So what do the other experienced clinicians think? So Robin, welcome. Robin Neifeld is here calling in, and he will, he's the senior author of the next paper we discuss. What is your feeling about the combined use of ECG and CMR in patients presenting, having seen this paper now?
Yeah, hi. Thanks for inviting me as well. Yeah, well, we do use it a lot, of course, during presentation of the patients, and on the basis of the EKG, you can have, together with the story, you have a feeling that it would fit myocarditis. I would not be very confident to stick to the EKG only, and would prefer to have some additional testing like an MR. But I think it's very helpful. And for prognosis, it's something that I learned today. It might be good as well. So, yeah.
Yeah, thank you. So if there are no other questions to that, I would like to then move to the next paper. So Kady, if you could unshare the screen, and I would ask Ahmet, Demirkiran, and Robin, who both are to present the paper published in the European Heart Journal Cardiovascular Imaging late last year, called Cardiovascular Magnetic Resonance Techniques for Tissue Characterization After Acute Myocardial Injury. So as opposed to what we usually do is just pure scientific studies, this is more a review paper, but I found it very important, and that's why I think it would be great to briefly go through that paper and, from your point of view, talk about the highlights of your research. So when you look through the literature of that paper, because cardiac MR, let's face it, the most important contribution is tissue characterization and acute injury, probably even more so than chronic injury, and that's why I found this review very important and also important to discuss. So I don't know, Robin and Ahmet, do you want to take it from here?
Yeah, sure. Thanks so much. I think, well, Ahmet wrote a terrific paper, the paper we just discussed. So what Ahmet and I said is that he will give a short introduction why we wrote this paper. And I think because it's a review paper, everyone just needs to read it as well. So we don't need to get into full detail of every part. But I think it would be good just to discuss the figures that we've put in the paper. And I think that's most helpful. So Ahmet, could you please tell me why you wrote the paper and why were you in Amsterdam?
Thanks, Matthias, and thanks, Robin. I'm glad to be here, and I'm really glad that this review was selected to be discussed in this nice platform. Actually, I'm in Amsterdam to pursue my dreams. So as a cardiologist, I wanted to be an expert in CMR, and now more broadly, I'm focusing on CMR techniques for tissue characterization after acute myocardial injury. And then I noticed an important need in the field, especially for the clinicians, that CMR is not only able to address important problems with cardiac volume and function assessment, but now it can also visualize and, more importantly, quantify myocardial injury after myocardial infarction. So, but in that field, I didn't see a reference review that can help clinicians to understand the basics of the new advanced CMR techniques to assess myocardial injury after myocardial infarction. And then from that point, I started writing this paper, and then with great help of Robin, we finalized it, and then I'm glad that it's appreciated by the European Heart Journal Cardiovascular Imaging. So CMR can also assess the myocardial injury by accurate methods of quantification. And in this paper, we also provided an imaging protocol for clinicians, how they can use these advanced techniques in their daily clinical practice. So mainly this was the aim, and hopefully we were accomplished that. And now I'm giving the word to Robin. I'm sure Robin and you, Matthias, and other experts are gonna discuss this review extensively and effectively. Thanks for the opportunity.
Yeah, sure. So what we've done in this paper, after the short introduction that Ahmet gave, is also a short introduction in the paper, of course, we discuss every technique that we've had before, like T2 weighted imaging, early enhancement, first pass perfusion, and late gadolinium enhancement. And I think it's the beauty of this paper is that it shortly discusses the technique, how it works on a technical point of view, and then what the data is, where we can use it for, and what the prognostic value is of these techniques in patients after acute coronary syndromes, because that's the patient group that we study in this review. So first, the T2 weighted imaging, that's something we've just seen in the paper with myocarditis as well. and the contrast agent dependent techniques. I think a lot of people know how that works, how the technique works, and what the value is of these techniques. More importantly, so we have here that we call them the traditional CMR acquisitions, the CINEs, T2 weighted imaging, and late gadolinium enhancement. But we also have the newer CMR mapping acquisitions for infarct tissue characterization. And with those techniques, it seems to be all very easy to understand. But I think in this paper, we shortly discussed the technique as well, but also the pitfalls of the techniques. Because in infarcted tissue, you have very different things going on in the core of the infarct, with hemorrhage, with edema, with myocyte necrosis, and all these things come together in one map and give you just one single value. And you need to understand what the value is and what it does to know where you're looking at. Because if you're unlucky, the T1 map can be, in a global assessment, pretty much normal, while the different regions have very different degrees of myocardial damage. So as you can see here, for example, in the T2 weighted image, you can clearly see that the white part is edema. In the center, there's hemorrhage. And if you look at the T2 map, which is below the stir image, you can exactly see more or less the same. You have a dark signal in the core, which is hemorrhage, but there's also edema in that point. So if you add that up, the number will be more or less the same as remote myocardium. So don't think that your T2 mapping is not working or you have an artifact. It's very logical if you understand how the technique works. On the border of the infarct, you can see that there's a high number, 82, which means that there's edema over there, and that fits exactly the T2 stirred image. If you look at the quantification of what happens here in the core, you can use T2 star mapping, and that provides you a number which is very low in this case, because in the infarct core, where there's microvascular obstruction or microvascular injury, it's just how you want to call it, you can see that there's hemorrhage over there with a very low T2 star number. On the border, however, where there is infarct, T2 star is normal, more or less, comparable to the one in the septum where there's not an infarct at all. If we go back to the first image in the T1 map, you can see that the T1 map more or less provides you everything. A low number in the area of hemorrhage, a high number in the area where there is edema or myocyte necrosis, and then the normal value or maybe slightly higher in the area where there is no acute infarct. So I think this illustration is very easy to remind yourself and to use in clinical practice, like what are the numbers that I'm looking at? And at the end of the article, we provide a scheme for every acute coronary syndrome disease, like the one that I've just displayed, is acute infarction, but you can also look at it in chronic infarction, minoca, myocarditis, or Takotsuka cardiomyopathy. Those three are suspected acute coronary syndrome cases, but after MR, we know what kind of cases those are. And here you can see in the lower parts what I've just explained, the high T1 value and T2 value in the border of the acute infarct, and the low T1 and T2 and T2 star value, at least the T2 star value and T1 value in the infarct core where there is hemorrhage. So I think those schemes will help you to understand what's going on after you, or you do CMR mapping, or after you acquire the T2 weighted images or the late gadolinium enhancement images. And then there's one other scheme I would like to discuss with you. Sorry, it's a little bit up above. And that's this one. And that's just to provide you some, how you say that, like flow chart. If you have a patient with a suspected ACS and you want to do the whole workup from scout imaging to CINEs to T2 weighted imaging, mapping, contrast administration, first pass perfusion, short access CINEs, and late gadolinium enhancement, you know that you will be up and running like for 35 minutes to get the whole scan, but you can leave parts out of it if you're pretty sure what kind of patient you have in your scanner. So I think this is a scheme that you can use in daily practice. You can keep it as short as you like or as short as it's needed because you don't have that much time for scanning. And I think that would be helpful to choose the right CMR sequences for the indication you have. So Ahmet, do you have any additional comments or figures that you would like to explain to the group?
Maybe I can say some small things. In the imaging protocol, if we are really limited with the time constraints, maybe we might only use cine imaging and the late gadolinium enhancement imaging techniques to because they are the ones resulting in the most significant results for prognosis. This was one of the important things we highlighted in the review. And additionally, if we look at the last image, the following one here. So it's important. There's also a confusion for the terms being used in this area, but maybe we can make it a bit more clear. Intramyocardial hemorrhage we are mostly using for non-contrast dependent techniques, because the intramyocardial hemorrhage is appearing in T2-weighted imaging due to consequence of degradation of hemoglobin products. But in LG images, we see we name it as microvascular obstruction because actually there is no contrast in that area, in the darkest area in the LG images, because there is no contrast getting into that area. But as a general term, maybe we might use an umbrella term every time this is true to use. It is safe, microvascular injury. There are many papers going on, also under supervision of Robin, many papers was published, but still it's not much clear what are the differences between intramyocardial hemorrhage and microvascular obstruction. They can appear both together, or sometimes you might only detect microvascular obstruction, but not intramyocardial hemorrhage. So CMR with advancements offering more in this field to us to understand the pathophysiology of this myocardial injury. And hopefully in the near future with more advancements, we are going to understand more and maybe we can more effectively treat patients.
Thank you very much. Actually, to that topic, we did some research on that, and I thought a lot about microvascular obstruction and hemorrhage. My guess is, and I'm happy to be convinced otherwise, but until I'm not, my hypothesis is that it is always hemorrhage. It's just in cases where the hemorrhage is very small, we have partial volume effects and cannot necessarily identify that properly with T2 star. But we have done a histological study a couple of years ago, and in fact, microvascular obstruction was always there if there was a hemorrhage. We had cases where there was only microvascular obstruction, but no hemorrhage. But when we looked histologically, there was also some hemorrhage. And I think what we have to assume, what you have to keep in mind is that any hemorrhage leads to a massive inflammatory response with edema that compresses capillaries and will reduce blood flow to that region. So that's why I think MVO and hemorrhage are linked, with hemorrhage being the basically the underlying mechanism, and just sometimes it's so small that the associated microvascular obstruction is larger than the hemorrhage. What we can see, it's always larger, but the hemorrhage is too small for us to see. But that's the hypothesis, and that's maybe taking us too far away. I just wanted to know that. So thank you very much. I think the figures you pointed out here are very instructive, and I think especially these flow charts, we need to have standardization of such flow charts, and hopefully some of the I know that some of the papers that are coming up from the SCMR will attempt some of that, but you did a particularly great job here. One question I have to you, Robin and Ahmet, what is your take on doing images without contrast agents? Saying we take a T1 map, a T2 map, and a cine, and then we'll try to figure out what's going on. I know in the Lake Louise criteria, we took that step. We said, okay, if both are negative or both are positive, then it's okay. If one of them is positive and the other one is negative, then you have to do contrast enhanced imaging. What's your take on that? And we have to have a short answer because we're already at the top of the hour.
Yeah, I'll give a very brief answer. I think we're mostly use contrast, and we use it really, really quickly, because you put the contrast in, put the patient in the scanner, do your cines, and then you have your late GAT and you're done. And I think it's so easy to work in that workflow that clinically seen, it's the most easiest way to get your answer. But if you have more time, I think T1, T2 star mapping would be enough, and you don't need any late GAT. But I think we need years to change that.
Okay, so there was a question from Cecilia asking for the full PDF, but just a reminder, everybody who is a member of the CMR Journal Club has access to the PDF versions of the discussed papers. It's not for public, but those who are members of the club have signed up. They have access to the PDF, so you can do that anyway. Thank you very much, Robin and Ahmet. If you could unshare yours. So before I let everybody go, I wanted to just briefly mention, in 2 weeks we have our next journal club, and then we will discuss the following 2 papers. One is, and I'll show that here, from a Japanese group, and it's called 3-Dimensional Assessment of Coronary High-Intensity Plaques with T1 Cardiovascular MR Images to Predict Procedural Myocardial Injury. And then the other one will be on hyperacute cardiovascular MR T1 mapping, predicting infarct characteristics in patients with ST elevation myocardial infarction. So in 2 weeks, hope to see you there. And again, thank you very much, everybody, for joining. And I wish everybody a good evening in Europe and a good day here in North America. So all the best and take care.